Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise. Welcome to the show. Hey, if you're watching us live, you can watch us on YouTube, LinkedIn, Facebook, and on X. We come to you every week at 9 a.m. Central Time on all those channels. If this is your first time joining us, great. Welcome to the show. You can learn more about the show by visiting our website at uronurse.com. Best place to go to learn more about the show. Absolutely the best place if you want to watch the past episodes, all 146 of them as of today. They're all up there. Just go to the website. You'll be able to check them all out. Hey, some of you like to listen in your car. I know I have about a 1 hour commute to get to work, and this really is a good way to kill time is listening to a good podcast. We're available on Apple Podcasts, Spotify, iHeartRadio, Amazon, and YouTube Music. So you pick it every week. It'll show up right in your box. The audio podcast comes out about a half hour after the live show airs every week. And hey, this May is Happy Nurses Week and Happy Nurses Month. So enjoy it as we celebrate. Got a great speaker today. This is Patrick McCallum is going to be speaking to us today about what it is to be a nurse anesthetist. He gave a presentation at a recent Chicago Metro SUNA meeting, and it was fantastic. I talked him into coming on live. So let's bring everybody in now. Hey, welcome to the show, everyone. How are you doing? I'm going to let you all give your own introductions. So let's start with Lori. Lori, go ahead and introduce yourself.
Hi, good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology since 1998. And I'm currently working for a large urology practice in Geneva and Winfield, Illinois.
All right. And Patrick, go ahead and give us your introduction.
I'm Patrick McElhone. Thank you for having me, Vic, today. I am a nurse anesthetist. I've been a nurse anesthetist since 2001. I am currently the chief nurse anesthetist at Hines VA Hospital, which is a larger VA hospital right outside of Chicago, Illinois. And I'm also a lieutenant colonel in the U.S. Army Reserves.
Oh, thank you for your service.
Thank you.
All right. And of course, I'm the host of the show. I've been involved in urology for the past 40 years and just having a ball doing this, giving back to you guys and bringing great shows like this to you. So let's bring Patrick's slides up and Patrick, take.
Thank you. Again, thanks for the introduction, Vic, and I'm happy to be on your show today. So this is, again, a lecture that I gave a couple weeks ago, and Vic did ask me to give the lecture to y'all, and it's really my pleasure to be here. So I'm going to talk about anesthesia for urology. And Vic, do I control the slides or do you? I'm sorry for asking. There you go. Got it right there. Perfect.
You got it. Yeah.
So I'm a nurse anesthetist, and I appreciate being on the UroNurse podcast because I know one thing I'd like to talk about is kind of the similarities between nurse anesthesia and urology nursing. And that might seem totally like they're two totally separate sides of everything, but they're really not. What it's really about is about building almost instant rapport. And I really appreciate everything you guys do as a nurse because I want to have rapport with people so they trust me really with their lives. Anesthesia likes to say, we walk this fine line and we hold people's lives in our hands. But the truth is that does take a certain kind of trust. But I want to just say to you guys, it takes really kinds of trust to be a urology nurse. It takes people trusting you with, their issues with their sexual health and their urination health, extremely private matters. And I think it almost takes them to trust you more with these very personal issues than it does to trust me really with their life while they're undergoing anesthesia for their surgery and procedural care. So just want to say that. The second thing I want to say is I'm a nurse anesthetist. I approach anesthesia through a nursing paradigm. And that's really what I'll talk to a lot about in this lecture and maybe even answer some questions for afterwards. So my foremothers really did create this profession, the profession of nurse anesthesia in the U.S., really the profession of anesthesia through the nursing framework. And one big thing that I'd like to do is talk about the nursing framework too within anesthesia. So when we talk about anesthesia, people say, well, what is anesthesia? And there's all kinds of definitions for it. But for me, anesthesia just comes down to these four things, which we call the 4 A's of anesthesia. And these are really what anesthesia really is. And it's really a balance between all 4 of these things. The first thing being anxiolysis or amnesia. So we call that the first A. And this is really, the medications that do this, I'll get into a little bit, but this is really the overall sedation, the taking care of anxiety. The next thing is very obvious, analgesia. And you can see those are at the 12 o'clock and the 6 o'clock position on my diagram, because those are really what most people think of for anesthesia. We want them to be relaxed, maybe even amnestic, depending on the depth of anesthesia and the nature of the procedure. But we really want them to be pain-free. And when we talk about patient comfort, and as a nurse, that's one of my primary things is patient comfort. I'm really looking at these two. These two are truly the pillars of anesthesia, anxiolysis/amnesia and analgesia. The other two that we see at 3 o'clock and at 9 o'clock on my diagram are autonomic stability and akinesia. Autonomic stability meaning that as people undergo these procedures, whether they're just anxiety producing or painful, we are going to trigger an autonomic response. And we might see that with high blood pressure or increased heart rate. We might see it as a low blood pressure or a low heart rate if we do vagal stimulation. But again, if we can kind of balance those first two, anxiolysis and analgesia, autonomic stability tends to take care of itself. The last one is akinesia, or meaning just we want a quiet surgical field. We often see movement under anesthesia, but a big thing to remember is that movement is actually reflexive, not conscious movement. So when we do anesthesia, it always, for me, comes back to controlling these four things: anxiolysis/amnesia, analgesia, autonomic stability, and akinesia. So we talk about a continuum of anesthesia. I do a lot of work for VA policy, and one policy that I really work with a lot is the moderate sedation and the deep sedation, and we talk about conscious sedation, and then we talk about general anesthesia. But for anesthesia personnel, this is all just one continuum that really starts with minimal sedation, and you can see that might be a very common drug like midazolam, or even a oral benzodiazepine like Xanax, and it might go into a little bit deeper sedation, or a monitored anesthesia care where we're now using propofol for our amnestic or anxiolytic. We might be adding some IV opioids such as fentanyl for our analgesia, or we might be using a non-opioid analgesic like ketamine. And then finally at the end, we might be layering in a paralytic or a muscle relaxant to get that akinesia. And you can see that, it just, for me, you can see this continuum in this slide right here. So what is monitored anesthesia care versus local MAC? So we might see this in urology for procedures where localization can be our primary way of analgesia. This might be a cystoscopy where we use lidocaine jelly into the urethra. It might be a circumcision or a prostate biopsy where the urologist will be injecting local anesthetic either for a circumcision into a penile block, or a prostate biopsy into the prostate itself. And what we see is that local anesthetic can take care of that analgesia. Because that's actually a pretty good job at stopping pain, we can do a lot of these procedures under local only, but for certain patients, we really need to layer in that anxiolysis. So again, when we talk about monitored anesthesia care, we're really talking about procedures that aren't that painful, or that we can take care of with local anesthesia, where the anesthetic will really be addressing that anxiolysis or that amnestic point of view. The big thing we want to do is take care of patients' anxiety in these. So again, when we go back to our paradigm, in a monitored anesthetic care, or a local MAC, as I like to refer to them, because the local is extremely important, we see the local anesthetic being that source of analgesia. So what anesthesia would do is just add in a small amount of IV amnestic or anxiolytic medication, such as a benzodiazepine or propofol. And our other two, our 9 o'clock and our 3 o'clock positions, our autonomic stability or akinesia, really we can make people comfortable such that they'll relax and they'll be very still through the procedure because they're comfortable. And also because we do a very good job at taking care of their anxiety and taking care of their analgesia, we really don't see an autonomic response. Kind of moving on the continuum, we talk about neural axial anesthesia. And remember, in neuroaxial anesthesia or spinal cord anesthesia, we're introducing a small amount of local anesthetic at the spinal cord level. For urology procedures, we usually look at the dermatome level about T10. That's about where the belly button or the umbilicus is. And we really want to block sensation coming up from the periphery into the spinal cord at this level. This is very good for providing denser analgesia, more than a local field block could do. And this will kind of take care of that analgesia. However, we still have the anxiolysis. We still have the fact that, urology procedures can be somewhat embarrassing for patients. That embarrassment can cause anxiolysis. So in these procedures, even though we would do the spinal or the epidural, we would still give them most likely a propofol to help with this amnesia or amnesia, where they might even, or anxiolysis. We can also put an epidural in, which is a little bit long. Remember, in the epidural, we find the epidural space, which is the outermost covering of the brain and spinal cord. It extends from about the top of the head all the way down to the sacrum, to the top of the vertebral column all the way down to the sacrum. And it's about 5 millimeters wide. We find that space and we put a small plastic catheter into it. Now, if we're doing larger urology procedures, such as nephrectomies or cystectomies, we can actually use this epidural in the postoperative period to help provide analgesia with very minimal to no opioid. And when we start looking at ERAS protocols, I know that's not what this lecture is about, we can see that there. So again, as I said, the epidural space is a potential space outside the dura mater. It's filled with loose connective tissue, fat, and blood vessels, and extends from the foramen magnum, or really the top of the spinal vertebral column, all the way down to the sacral hiatus. That subarachnoid space, or also called an intrathecal space, intrathecal meaning within the theca, which is that sac that the spinal cord is in, or subarachnoid meaning under the arachnoid mater, which is one of the coverings of the brain and spinal cord. We put a small amount of local into there. That local then diffuses into the spinal cord and into the spinal nerves coming in, and then blocks that sensation moving in. We can see here's just a cartoon or a drawing of that epidural space. And you can see it really going from the top of the spinal canal all the way down to the sacral hiatus. Again, another picture of the spinal cord. On the left, you can see the spinal cord ends at that L2 or L3 level, which is why we generally put a subarachnoid block, or commonly called a spinal anesthetic, around the L3 interspace, which should be about 2 centimeters below where the spinal cord ends, because we are entering the same space that the spinal cord is in. We want to be below that. The epidural is on the right. You can see that cartoon, and you can see that right kind of beyond that vertebral body, you can see the spinal cord and the spinal nerves in the cartoon, and you can see that epidural space kind of between that black area and that bone. That's where we want to place that plastic catheter. Here's a radiology view. What we see is that vertebral body in the front, and the spinous process in the back. You can see the spinal cord there and the spinal nerves coming in. And really what we want to be is in that black space at 12 o'clock. That's that epidural space where we want to introduce that small plastic catheter. And again, we use needles. We numb up the skin. We use an introducer needle. We find that through going very, very slowly. Once we enter that space, we can feel it because the syringe that we're using will lose resistance. And then we thread that small plastic catheter into it. Medicine will spread up through that spinal, through the epidural space, and it will actually diffuse through the epidural space to interact some with the spinal cord, but will also move around to the side and block those spinal nerves as they're coming in, bringing in that painful stimulation. Lumbar epidurals are kind of easier to place. They're great for lower abdominal or lower extremity cases. However, they can cause weakness in the extremities. When we're doing them for bigger urology procedures, we like to place them in the thoracic area. This can work more with where the nerves are coming in from the site of surgery or the incision primarily, and we can spare the lower extremities. So we can actually place an epidural higher and patients can walk. We call these walking epidurals, and this is generally what we use for postoperative pain control. We talked about dermatomes. Spinal nerves innervate different areas. of the body, and based on where the skin is feeling the sensation, we can determine what level of spinal blockade we have. Common ones are T4 at the nipples, T6 are at the xiphoid process, T8 is the rib cage, T10 is the umbilicus, and the hip is usually about L1. And usually for urology procedures, we like to be about right around T12 to T6. So now we're back to our picture. You can see again with spinal anesthetics or epidural anesthetics, these are great at taking care of the analgesia. Now, if it's a bigger urology case, we'll usually do general anesthesia on top of it to give that really, really deep level of depth of anesthesia where we will get amnesia. We usually use inhalation agent for that. Now, one thing though that we have to talk about with autonomic instability with spinals and epidurals is that the sympathetic, the efferent sympathetics, so those are the sympathetics that move away from the spinal cord, those are actually very easily blocked because of the size of the fibers. So when we do a spinal anesthetic or we do an epidural anesthetic, we can see the blocking of these efferent or the sympathetic nerves. What that actually does is that actually cuts off neurotone or vascular tone, where we can see some vasodilation, and that can in turn lead to increase in the size of the venous blood vessels. That will lead to decreased cardiac output, which can lead to a drop in blood pressure. So it's not common when you're doing spinals or epidurals to have to give some patients a little bit more fluid. And all we're doing with that fluid is as the venous side of the blood vessels get bigger, we increase the capacitance of the vascular space. So we give IV fluid to kind of fill up that vascular space. We can give vasoactive medicines, ephedrine, phenylephrine are extremely common in anesthesia to actually counteract the vasodilatory effects of the local anesthetic introduced at that spinal level. And those act again by kind of going the whole body and increasing vascular tone. Spinal anesthetics do provide a great degree of akinesia. You actually block muscle fibers below the level of the blockade. So you do see muscle relaxation and patients are not able to move. This is great for a spinal anesthetic, especially for some urology procedures. However, it's not necessarily great for post-op because we want patients to be able to get up and walk and move. We're going to talk about general anesthesia now. General anesthesia is the most common, and you can see that general anesthesia in and of itself provides 4 aspects of anesthesia. It provides anxiolysis and amnesia, either through IV anesthetics, such as propofol is a very common one now, but the most common one is actually the inhalation agents, what we now know as sevoflurane or isoflurane or desflurane. General anesthesia now is usually given through supplemental IV medications. Akinesia can be given. We can add a muscle relaxant, or also known as a paralytic, such as rocuronium or vecuronium or cisatracurium, to provide additional muscle relaxation. And we can see some autonomic instability because of these general anesthetics really make everything go to sleep. And that's really great for making the brain go to sleep. But it also, again, makes the sympathetic nervous system go to sleep a little bit. And when the sympathetic nervous system goes to sleep, we do see that vasodilation that I talked about under epidural and spinal anesthetic. So it's not uncommon to see some lowering of the blood pressure. Inhalation anesthetic is the primary way that we give general anesthesia. And these are vapors that induce and maintain anesthesia. Even in 2025, we're unsure of the exact mechanism of action, but inhalation anesthesia in and of itself provides all 4 aspects of anesthesia. And again, anesthesia was discovered in the 1840s. Depending on what side you believe, it was either discovered in Georgia by a gentleman named Crawford Long, or it was discovered in New England by a gentleman named William Morton. And for about 100 years, all anesthetics were only done with inhalation agent. So I'll say that again. In about 100 years, all inhalation was done through, all anesthesia was done through inhalation anesthesia. Because inhalation anesthesia does provide all 4 aspects of anesthesia. It will provide amnesia, anxiolysis. It will provide analgesia. It will provide for a quiet surgical field. And something very magical about anesthesia is the way anesthesia is coupled to respirations. And this is actually how we could give anesthesia for 100 years without any really deep monitors. What we would do is by just looking at how the patient was breathing, we could determine whether they needed more or less anesthetic. And when people are comfortable, and wide awake, they have a very regular respiratory pattern. When people are light in anesthesia, they actually increase their respiratory rate and increase their depth. When people are comfortable under anesthesia, they go back to a regular respiratory pattern. And as people started to get too much anesthesia, they would actually develop an ineffective respiratory pattern, which we would see of the chest wall being disconnected from the diaphragm. So the chest excursion and diaphragm movement would not be in sync. They would decouple. So when my foremothers were giving anesthesia, they would be watching the patient and how they breathe. If the patient began to get light, the patient would actually increase their minute ventilation. They would drop more ether onto a mask, and the patient would actually uptake more anesthetic. If the patient began to get too much anesthesia and they started to decouple and breathe ineffectively, they would remove the mask. And by removing the mask, the patients would no longer be breathing in any anesthesia. So the gradient would reverse and they would then exhale only anesthetic without breathing any in. And that would cause the overall depth of anesthesia to be lowered. And again, Vic, I can't tell you how important breathing really was. And it was this magical connection between inhalation anesthetic and depth of anesthesia that truly allowed anesthesia to be given safely without any monitors for 100 years. Now, what that did require, though, and anybody who works in the operating room will know that anesthesia is not great at doing this anymore, is it required incredible vigilance and it required being very in tune to your patient and almost feeling that patient's energy and really being in-depthly connected. All these pictures that I have in my presentation of nurses doing anesthesia, you can see they're always facing the surgical field. And they're not so much watching surgery. And in this picture on this screen right now, you can see that because that ether drape is up. And that ether would prevent ether from moving into the surgical field. But you can look at that nurse's eyes and you can really see that nurse is really looking at that chest wall and looking at seeing at how that chest wall is going to either give more or less anesthesia. Again, in 2025, we really don't do pure inhalational anesthesia anymore. We do this balance, where we call balance anesthesia. Well, we'll give specific medications to target all four of these aspects. So in a big general anesthetic case, it won't be uncommon for me to give a little bit of benzodiazepine to help with anxiolysis when we're rolling into the operating room. I'll induce with an IV anesthetic, such as propofol, and I'll maintain amnesia with inhalation agent. I'll give opioid or non-opioid analgesics to help with the analgesic point of view. And because I can use opioids, I can use less inhalation agent or less IV anesthetic. This will actually help patients wake up quicker and increase throughput, which is oh so important in today's healthcare environment. However, because I'm giving less anesthesia and less inhalation agent and maybe less opioid, now I really need to layer in that muscle relaxant or that paralytic to create that quiet surgical field. Again, when we talk about movement, we talk about that being a reflex. If we were to grab a hot frying pan, we would let go of it right away without saying ourselves, this is really hot, I shouldn't be holding it. And that's what we see. We see reflexive patient movement that can create movement on the surgical field, which our surgical colleagues really need that quiet surgical field to get in there and fix that surgical disease. And finally, what we see is we usually do intubate people now, and when we give a muscle relaxant, we have to put them on the ventilator. That's fine, we can safely do that, but what we've removed is removed that respiration as a guide to depth of anesthesia. That can lead to both overdosing and underdosing of anesthetics, and that can then lead to autonomic instability. So you see us on one hand, if we give too much anesthesia, having to give ephedrine or phenylephrine. And if we give too little anesthesia, we might see increased heart rate or increase in blood pressure. And we might have to give esmolol or labetalol, something to block that catecholamine surge to prevent blood pressure that's too high that could lead to surgical blood loss or could lead to overall stress for the patient. So again, we have, if anyone's looked over, has been in the operating room and you look at the anesthesia cart, you'll see stickers on the top of it or drug labels. And these are really color coded in a very specific reason. And this color coding really goes back to everything we just said. The orange is the benzodiazepines that we use for anxiolytics. The yellow are the IV anesthetics, such as propofol. The blue are the opioid anesthetics. The red are our paralytics. The green are actually anticholinergic or vagolytic drugs. The purple are sympathomimetics or vasopressors. The white is everything else, and the red is paralytics. And an interesting thing is if you look at the reversal agents for opioids, well, they're actually white with the blue slash lines over it. The same for benzodiazepines. They're orange because orange is the color for benzodiazepines. They're white with orange slash lines through it. And the same thing with our Sugamidex and neostigmine, the medication we use to reverse our paralytics, are red with a line through it. So again, in 2025, we no longer just do inhalation anesthesia and we do balanced anesthesia. But as we make things more as we add things in, we make them more complex. So again, when we talk about general anesthesia, now we're really having to be vigilant to make sure that we're using separate medications to achieve all four aspects of anesthesia. Real quick, airway management. This is where anesthesia really gets known in the world. And part of the reason why we are known for airway management is we truly do airway management on every case. And because we do it every day, we become very skilled at it. The biggest thing to know about airway management is apnea. Apnea is actually not so much caused by direct acting on the central nervous system. It's caused by that overall muscle relaxation that we can see from in a sedation case or a MAC case, and in the supine position where the tongue gets relaxed and it collapses back and blocks the airway. Again, muscle relaxants and opioids can also cause apnea. And in those cases, we would have to either reverse or intervene with an endotracheal tube. So real quick, 5 tools to open the airway. They're all in our hand. We can use an oral airway or a nasal airway. We can use our hand to use a head tilt chin lift. We can use a supraglottic airway like an LMA or a iGel. And these are little masks that actually sit in the back of the throat in the posterior pharynx, right above the larynx or that opening into our trachea. They form a really good seal, and we can ventilate through those, or we can allow patients to breathe inhalation agents through those. We can also use an endotracheal tube. And then that last thing we can use is we can actually do a surgical airway to open up the airway surgically at the level of either the cricoid or the thyroid cartilages. So here's just a quick cartoon to show the 2 ways to open with our hands, head tilt chin lift or a jaw thrust. You can see the oral airway goes in and then the nasal airway goes in. And what those are really doing is lifting that tongue that's collapsed off the posterior pharynx, opening up a channel for the patient to breathe through. We can see a supraglottic airway. Again, that's that mask that sits right above the glottic opening up the airway and allowing the delivery of inhalation agent through there in a rather good seal. We can see obviously what everybody's familiar with, the endotracheal tube. That goes into the trachea, inside trachea, where it goes through the glottic opening and sits in the trachea and is sealed off. That allows probably the best connection and the best ability to ventilate. So just kind of pivoting, and we'll talk about a couple of common urology procedures, a couple of urology procedures that I do quite often, and what I think about in those procedures of how I do anesthesia. So a cystoscopy is a very common procedure. Well, what kind of anesthesia do I need? Well, that really depends on what are they doing with the cystoscopy. If it's maybe a surveillance cystoscopy where analgesia can be done, again, through just some lidocaine jelly through the urethra, I might just need to give a little bit of propofol or something to help with kind of just, that most people aren't comfortable with their urethra being instrumented and a surgeon really being between their legs with their legs up in the lithotomy position. Again, a very anxiety producing procedure. So I would come in and I would just give some anxiolytic or some amnestic to just help people be comfortable through it. What if it was doing a little bit more? What if it was a lithotripsy? Well, those can be painful. So now I would either probably beyond pain that we can control with local anesthesia. So I might have to do a spinal anesthetic, such as for a TURP. What about a TURBT, where we're going to get into stimulating the obturator nerve? Well, now maybe I have to layer in a paralytic to prevent that nerve from firing and causing a movement of the surgical field. So we can see that like we have to look very carefully at not just the procedure, but how can we achieve analgesia? How can we maximize comfort? And then we're going to build our anesthetic plan from there. What about an open nephrectomy? What type of anesthesia? Now, this is a very large incision. It requires very good surgical exposure. So I'm going to most likely do a general anesthetic. I'm going to put an endotracheal tube in because it could be rather long, and I want to make sure the patient is breathing appropriately throughout the whole time. It can be painful, so I either need to layer in some really strong pain medicines or perhaps even do an epidural that can help with controlling pain in the operative period, and then I can continue that epidural in the postoperative period for analgesia. Because it requires a lot of exposure, additional muscle relaxant will probably be needed to allow for great surgical exposure so the surgeon can get in there, remove that kidney. And with all this pushing and pulling and anesthesia and maybe even blood loss, we're going to see some autonomic instability. So I need to think about IV access if we're going to get into blood loss. I need to think about additional monitoring, such as placing an intra-arterial catheter to monitor blood pressure continuously. Vic, I appreciate your time. What questions can I answer for you guys regarding the presentation or nurse anesthesia as a whole?
Yeah, just going to bring in our audience. Anybody who has a question that's watching live, feel free to put it in through the comment box. We'll be glad to bring those in here. Lori, welcome again to the show. Lori, you have any questions you want to lead off with?
It was a great presentation. Thank you. It makes us understand, the different types of anesthesia used for different procedures. I love that. I had a question. This is more, I think, on the urology base side. Well, it's kind of all, I guess. Can you touch base on any of a post-op urinary retention related to anesthesia and when catheters are necessary, when they're not necessary, how long do they have to stay and things like that?
It's a great question. So yes, as we can see, anesthesia, there's various kinds of anesthesias that can interact with that can cause postoperative urinary retention. The most common one being opioids. And you can see that people frequently use opioids as a way to capture that analgesic component. So we do see that. I wish I could say it's going to last this long or that long. We truly don't know. We truly don't know how long it'll last. Anywhere from, I've seen 2 or 3 hours up to 24 hours. Opioids are by far our most common one. The next way we see that is actually with spinal anesthetics. Sometimes we do put opioids into spinal anesthetics to help hit those opioid receptors in the spinal cord. Those can contribute to it, as can local anesthetics on itself. And that they do interfere with afferent muscle control of the urinary sphincter and the ability to urinate. Again, that effect is actually a lot longer than what we see with the overall motor blockade for the lower extremities. So it's not uncommon to see that. I don't know right off the top of my head what the range is, but I've seen that last for up to 24 hours. And unfortunately, that can, in our United States healthcare system, where we are trying to really increase that surgical throughput, urinary retention can be an issue. You see more and more people thinking about opioid sparing techniques, especially for general anesthesia, where we avoid opioids. And that is certainly one way that we can address that by using non-opioid analgesics, such as ketamine or acetaminophen, ketorolac, or if it's appropriate, dexmedetomidine, combined with peripheral local anesthesia. That is a way that you can help with that decreasing urinary retention. And that's especially an option if you have somebody who were to say to you, hey, after my last anesthetic, I really couldn't urinate for a whole, I had to be admitted. It was 12 or 14 hours. That's really something to consider is moving towards an opioid sparing technique.
Thank you.
Yeah, great question. So I had a question for you. I get a little confused sometimes with what the choice should be when you're looking at like epidural versus spinal. What's the difference as far as what cases can be done with each one?
They're very similar because they're both what we call neural axial anesthesia. So they're both providing anesthesia at that level of that spinal cord. And it is that complete almost a complete anesthetic, because it will provide profound analgesia, and it will also provide loss of motor control, which will lead to our akinesia. The primary difference, Vic, is really the time. That's what most of us will really look at, is the time. So a spinal anesthetic, the way we commonly practice in the United States, is we use bupivacaine. That's going to generally last about 3 hours. Now, we can change the doses and we can make those work for less amount of time, but really we're probably looking at about 3 hours for surgical anesthesia and probably another hour or so of urinary retention. Now, if it's going to be longer than that and you really don't want to do a general anesthetic, you can do that epidural. That epidural gives you that catheter, so you can continually dose that catheter throughout. There are people that do spinal catheters. That is a technique where you can kind of get the best of both worlds. That's kind of an advanced procedure that's not necessarily routinely done. I do know people who do that, and they do that very well. But for the most part, the only big difference that we're going to look at is duration of the procedure. Now, if we're doing a very large urology case, like I gave the example of the cystectomy, we might place that epidural to help us give less opioid during the operation, IV. And that's going to help with things like urinary retention. That's going to help with things like waking up faster, because you're not going to get the sedative effects of the opioid. And if we place that in the thoracic area, we can provide pretty good, excellent analgesia in the postoperative period while still allowing patients to move. And if we look at ERAS protocols, again, a little bit, not what we're necessarily talking about today, but one of the big keys about ERAS is getting that enhanced recovery after surgery. What we're really looking at is returning that patient to all of their functions as quickly as possible. And by having them return to their functions, we see them really, really improving surgical outcome. So the big quick ones right off the top of our head are by avoiding opioid with an epidural. We can see they're not going to be as sedative. They can breathe. They can breathe a lot better and a lot deeper to help with pneumonia. They can get up and start walking earlier if we place that at thoracic level versus being sedated from an opioid. And that movement can help with increasing venous return, decreasing the emphasis of DVTs to help with that postoperative complication of DVTs or even pulmonary embolism.
Great. Also, I wanted to just address the complication differences between epidural and spinal. And I've taken care of many patients that had spinal headaches post-op, and they are miserable. They are.
And generally, what happens with a spinal headache is we put that hole in that dura mater, and we introduce a small needle when we do a spinal anesthetic, usually a 25 gauge or 22 to 25 gauge, maybe even a 27 gauge. And the idea is that the smaller hole we put in, the lower risk we have of a spinal headache. So what happens in a spinal headache is actually that CSF, or cerebrospinal fluid, that's that fluid that the brain and spinal cord are bathed in, can start leaking out of the hole we put in. And as it leaks out, the brain, then it's floating in there, doesn't so much float, it sinks. And as it sinks, it actually pulls on the meninges. And the meninges are tissue that anchor the brain to the skull. And as that tension comes on the brain, that's what creates the headache. So in the classic spinal headache, when somebody lays down and now gravity is taken out of the equation, the brain doesn't sink down, they don't have a headache. Those are actually, believe it or not, more common with an epidural than a spinal. And it's an epidural where maybe they advance it too far. Again, that epidural space is only about 5 millimeters. So if you go too far, you can puncture that dura mater. And now we're not using that little bitty 25 gauge needle. We're usually using a 17 gauge needle. So that 17 gauge needle puts a bigger hole in the dura mater, and that causes that you will get CSF leaking out of that hole, and you will see a much higher incidence of spinal headache.
Yep.
And again, when you talk about a blood patch, which is the treatment for that, what you're doing in a blood patch is you're finding that epidural space again, and you're injecting about 20 cc's of their own blood into the epidural space with the idea that that blood will then cover that and clot, kind of sealing up that hole and preventing the loss of CSF. So now CSF can accumulate back in that spinal canal, and the brain can go back to floating in it, not pulling on the meninges.
Yeah. I didn't realize that the epidural would have a greater risk of causing that spinal headache if, as you said, if it wasn't done right.
It does. And it has to do with the size of the needle and that needle causing a size of the hole.
Yeah. I actually had that happen, and I had to have the blood patch as well. It was a horrible headache.
Was that for a labor epidural?
Yeah. Yep.
Yeah, and again, it is the size of that. I know in the military, I did a fair amount of blood patches on almost all of them were because soldiers would come in. They were, young college age soldiers. They would all complain of headaches, and they would quickly get lumbar puncture to rule out meningitis, but they used a 19 gauge needle in that. So that 19 gauge needle would put a big hole in the dura mater. These guys would have headaches, and almost every blood patch I did was the result of a young soldier getting an LP, lumbar puncture, to rule out meningitis.
Lori, I'm going to have you read our question from the audience.
Sure. From Susie, do you do the epidural when the patient is awake prior to surgical case?
Usually we do. Some people will do it asleep, but usually we like to do it awake because we want to really know. We still do these blind. There's more and more techniques coming out where we can do ultrasound guided ones, but we really need that patient feedback about where we are. You do feel for anatomical landmarks. You do try to guess where that epidural space is. And you may give them a small amount of anxiolytic because, again, you are placing a rather large needle into them, and it does go through between the vertebral, the spinous process into the epidural space. You do need them awake to give you some feedback and to ensure that it's in the right spot. It shouldn't be a painful procedure. We do use local anesthetic prior to putting it in, but we really want that feedback. If it starts to hurt, most likely we're doing something wrong.
Yeah, makes sense. All right. I don't see any other questions coming in here. Lori, do you have any other comments or questions that you had?
No, I think that was a great presentation. We appreciate you being here.
So, Patrick, maybe you can go in a little bit into what's involved with becoming a nurse anesthetist. What education you need. It's Nurses Month, so it's a big good time for you to kind of recruit.
It is Nurses Month, and I'm a proud nurse. I know, our profession is trying to figure out right now, what we are, and we're nurses. I mean, we truly are. And as I said earlier, we should be doing anesthesia through the nurse paradigm. Anesthesia in the United States is actually legally the profession of. There's 3 professions that do it. There's actually 4 professions that do anesthesia. Anesthesiology is the medical practice, and physician anesthesiologists have their practice governed by their state medical boards. Anesthesiologist assistants work under the license of a physician anesthesiologist. Now, dentists can also legally do anesthesia in the U.S. Dental anesthesiology is a subspecialty of dentistry, and their anesthesia is governed by their state board of dentistry. As a nurse anesthetist, I practice nurse anesthesia. It is very proud to say it is the oldest advanced practice profession. Came about during the Civil War in the 1860s, and I love my NP colleagues. I really, really do. I hold them in extremely high regard. But the nurse practitioner profession came about in the 1960s. So we've kind of lost that, this profession has been around since 1860. And again, when I talked about the inhalation agent and the ability to attune into the patient, we can really see that it is the profession of nursing. And it is really that nursing paradigm that I think allows nurse anesthetists to give anesthesia so successfully. So as a nurse, the number one thing I'm looking at as a nurse is really, really meeting those patients' needs until they can meet them themselves. That's what I think all of us do. I know when I went to nursing school, I learned the definition was the treatment and diagnosis of the human response to actual and potential illnesses. And I don't disagree with that. But for me, nursing is really about meeting those needs until the patient can meet them themselves, and then helping them to get back to the level to meet their needs. So I know, Vic, thanks for letting me go on that. And what I'm really trying to say is that, nursing is an awesome profession. Again, happy Nurses Month to all of us. But anesthesia nursing really is nursing. So the first thing I would say to everybody interested in it is embrace nursing. As advanced practice, it's very important that you have that nursing base. A bachelor's degree in nursing, and then several years of bedside nursing experience. Critical care experience is needed. That might be ICU, but that's really up to the program you look at, if emergency room counts or what really is critical care nursing. But again, for me, the biggest thing about that first couple, and what makes our profession so amazing, is you really have to have been it is advanced. So you have to advance from that base of bedside nursing. And we can't lose that. We have to hold that. So, you need several years, I think 1 to 2 years of critical care experience. And again, to me, that's what really sets us different than PAs or anesthesiologist assistants, is that we really are nurses, and we advance from that base of bedside nursing. From there, I think there's probably 110 programs in the United States. They're all now moved to the doctorate. Doctorate is the entry-level degree, and programs are generally about 36 months that involve both a mixture of classroom theory and hands-on experience.
Oh, that's great. That was really kind of interesting to know that anesthesia has been around for 100 years and that it started with nursing.
I mean, it really did. I mean, as I said, there's a argument in anesthesia on who did it first. William Morton demonstrated at Harvard, but he was actually a dentist, and Crawford Long was actually a surgeon. And Crawford Long, it's a very interesting story. They used to do ether frolics, and they would get high on ether. This is like late 1830s, 1840s, and they would punch each other. And they'd wake up the next day, and this is guys, right? Guys being guys. They'd punch each other, and they'd realize it didn't hurt to get punched. So then they thought Crawford Long's buddy had a cyst on his neck. So he said, well, how about if I give you ether and then I cut it off? So he did that. I believe it was in 1842 in rural Georgia. William Morton, about 2 years later, did this very similar thing in Harvard. And then if you can go to Mass General in Boston, you can see where the first anesthetic was given. I know we went on family vacation there a couple of years ago, and I drug all my kids there, and they just wanted, they didn't want to go to the ether dome, but I made them all go. But again, what we see that anesthesia really, especially early on, wasn't the main event. It's still not the main event. I mean, the main event of anesthesia is the surgery, is that surgical disease. And I know as urology nurses, you're very familiar with the amount of urological diseases that are surgical disease, and that the patient's there to fix that surgical disease. So surgery was really the star of the show, but they needed people dedicated to safely, guiding that patient through the anesthetic. And they really did grab the best nurses and either do on-the-job training or send them to formal schools. And the schools were really run by Catholic nuns. They were really run through the Midwest. I think the first one was actually in Portland. But you see this just great history of all the early anesthesia education was done by nurses. And this anesthesia education was attended by dentists and was attended by physicians. But it wasn't until I think 1920 when the first anesthesia residency came about in Madison, Wisconsin. So prior to that, all formal education was done by nurses. And again, it was done through that nursing paradigm. Our history has just been lost, Vic. It's just been lost. It's kind of tragic that people don't understand the history, and they don't realize how old it was, and they don't realize that it was truly, truly built and carried by our foremothers. I mean, really, it really was for 100 years, almost. I mean, we've been doing anesthesia. It's 2025. So if you figure the profession was launched in the 1860s, is actually the Civil War is actually what really spawned the profession. About 90% of all surgeries in the Civil War were done under anesthesia, either ether or chloroform. And part of the reason why was because, surgery wasn't real common before the Civil War. It just wasn't. But with the combat injuries, you did see an increasing need for surgery, wound debridements, amputations, and those were done under anesthesia. So that then just increased the volume. And by increasing the volume, more and more nurses got that training and got that repetition to develop expertise. And that's why we link the birth of the profession really to the Civil War. Because again, we saw both on the Union and the Confederate side, we saw just a massive explosion of surgery that then and again, anesthesia is from the 1840s and the Civil War was in the 1860s.
Yeah. Wow. Yeah, and it's amazing that, in today's day and age where we've got monitors everywhere for everything, that anesthesia was done with no monitors
Right.
safely.
But that monitor was truly that human connection. You know what I
Yeah.
mean? Like, and as nurses, we have to be in tune with our patient. I mean, and again, like you guys see this every day. I mean, again, I when I was speaking with you all several weeks ago, I really can't tell you how important it is in anesthesia, just like it is in urology, to get patients to trust you. If patients trust you, they will be comfortable with you. Now they've just revved down all of their anxiety. Now, again, whether that's talking about their, you guys talk to people about really their most intimate things, truly their most intimate things. And again, as I said to you, I would rather trust somebody with my life than talk to them about my sexual history or my my incontinence, or it's true. But it's that ability to relate as a human and put people at ease that allows both of our professions to truly do our job. And again, like, it's unfortunate because this part of anesthesia is getting lost. And there's lots of reasons it's getting lost, but it really just needs to be continued, that, it's about people trusting you. And if they trust you, their anxiety is down. If their anxiety is down, all those aspects of anesthesia that I talked about can really be done with just putting patients at ease. And you guys probably do that better than I do, because as you see them when the physician comes in, and I love all my physician colleagues, but as nurses, people relate to us differently. They relate to us as almost a one-on-one level, and they are going to confide in us. So.
Yeah. The one anesthesia you didn't mention is what we just call auditory anesthesia.
Yeah,
Just
it's
talk
okay.
to people, get their minds off of it. I mean, Lori probably can attest to this. The things that we do in urology, a lot of it's just because we keep their minds off of what we're doing.
And that's exactly we call that okay anesthesia. Like, it's going to be okay. It's going to be okay. But I mean, again, like holding somebody's hand as they're going off to sleep, like gently, putting my bare hand on their chest or just on their shoulder, just talking them through it. That's such an important part of decreasing anxiety, because again, we can see all that it's just really about maintaining patients' comfort. And when I talk about, meeting people's needs that they can't meet for themselves, everything I do in anesthesia is essentially that. We'll start with a basic one. They can't maintain their comfort during surgery. That's real easy, but they can't necessarily maintain their ability to breathe. So I'll put a breathing tube in and I'll adjust the ventilator. They can't maintain their warmth, so I'll put a bear hugger on. They can't maintain their hydration status, so I have to give a IV. Maybe they can't even maintain their oxygen delivery because we have a 4-liter blood loss, so I'll transfuse. But when I talk about the nursing paradigm, I really just talk about it coming back down to, meeting the patient's need during their surgical disease, their perioperative illness. And that's the big message that I'd like to share, is that as nurse anesthetists, that's what we always have to come back to, is what is the patient's needs and can I meet those needs? And I think you guys are on the exact same page. It's just, what is their urology needs, and what do I need to do to help meet this patient's urology needs until they can meet them, we can restore function, and they can meet them themselves.
And sometimes we get bogged down with the technology and forget it's the person that you're treating, not the disease, not the other.
We can't, right? Like, AI will never be able to maintain human connection. And I know I have a daughter about to start nursing school in a couple months, so she hears this all from me. That human element is so important to what we do, and that's why I know when we were all in nursing school in the late 80s, early 90s, there was a big talk about healthcare techs coming in, and nurses were the most expensive resources, and we saw a big push to try to get rid of RNs. And when we were all going through nursing school, there was that increased emphasis on, no, the RN is so important. And what it really is it's that human connection that we can't exist without human connections. We're social people. And I would just really like to, take the opportunity to say that continues in nursing anesthesia. That's no different in anesthesia nursing than it is in any other form of nursing.
Yeah. Well, Patrick, it's been great. I really appreciate all your insight. I think that we really learned a lot. Anything, last comments you have for us, Lori?
No, I think that's right. I agree with the whole nursing, real quick, I have a patient that, the doctors are in there to, tell them what they need, what they need to do, but they're not there to walk them through it necessarily the way that we do and the way that we can explain and make them feel comforted. So, and happy Nurses Week to everybody.
Yeah.
Well, thank you, Vic. Well, thank you, Lori. I really appreciate it. And again, thank you for just giving me the opportunity to share a little bit about the profession of nursing anesthesia. And just, again, we are nurses. We're all nurses. And we all might people might think we're different, but hopefully people remember at that core, it's about that human connection and it's about meeting their needs. So thank you again, Vic. Thank you again, Lori.
I got to bring up a little plug for next week's show.
In this educational module, Melissa Forden, DNP, provides a comprehensive overview of Clostridioides difficile infection, an increasingly common and serious healthcare concern. Learn about the prevalence, risk factors, and the critical interventions used to help prevent the spread of this dangerous pathogen. Topics covered include key C. diff infection trends, isolation precautions, antibiotic stewardship strategies, environmental cleaning best practices, and diagnosis and treatment approaches. Join us for a half-hour contact credit this May 24th.
So join us next week for that talk on C. diff. It's one of those things we sometimes forget about, and it's always a good idea to brush up on it. And hey, you're going to get a half a CE for joining us for it. So hey, thanks everybody for joining us this week, and we'll see everybody next week on UroNurse.